Welcome back to the deep dive. We are tackling a subject today that I think everyone thinks they understand from the headlines. But when you actually dig into the research, the reality is so much more complex.
And way more interesting, honestly.
Way more interesting. We're looking at OpenAI's 2026 pivot into the healthcare space.
It's a massive shift. I mean,
Yeah.
we were not just talking about a chatbot anymore. This is infrastructure.
Exactly. But before we get into all that, I really want to thank the partner making this deep dive possible, AI Opportune.
They're fantastic.
They really are. Listen, if you're trying to separate the signal from all the noise in AI, and there is so much noise, you need to be subscribed. Whether you're an investor, a founder, just anyone trying to stay relevant, AI Opportune curates the actual opportunities everyone else is missing. So go subscribe. It is absolutely worth your time.
100%. High-quality signal is so hard to find.
Yeah.
And they just nail it.
Okay, so let's get into it. I want to start with this term I found in the research that sounds really cozy, benign even, pajama time.
Right. Sounds like a Sunday morning with a coffee or something.
It really does. But in the medical world, this is actually a nightmare scenario, isn't it?
Oh, it is. In the industry, pajama time is it's a very dark, cynical term. It's all those hours a clinician spends doing documentation after the clinic is closed.
After the last patient is gone.
Exactly. The patients are gone, the lights are off, the doctor goes home, maybe has dinner, sees their family for 20 minutes, and then, opens their laptop on the couch in their pajamas to finish charting.
That is just, it's a bleak image. You think your doctor's off resting, but they're just doing data entry on your cholesterol levels at midnight.
And it's not just a few minutes. The scale of this is staggering. The American Medical Association, the AMA, they put out data showing that physicians spend nearly twice as much time on admin tasks as they do on actual patient care.
Wait, 2 to 1?
2 to 1.
That feels fundamentally broken.
It is broken. It's completely unsustainable. And that is the specific problem, that friction point that OpenAI is targeting with this 2026 rollout. They're not trying to replace the doctor's judgment. They're trying to kill pajama time.
So that sets the stage perfectly. We're moving from like a general purpose AI to very healthcare specific infrastructure.
Yeah.
But I have to ask, and I'm sure you're wondering this too, why now? I mean, ChatGPT has been around, doctors have it on their phones. Why wasn't this already solved?
That is the critical question.
Why did general AI fail medicine up to this point?
And the answer is really in the specific failures of those early models when you try to apply them to a high-stakes field like medicine. The sources call this pre-2026 period the shadow use era.
Shadow use sounds like a spy novel.
It was definitely risky behavior. I mean, you had clinicians who were just desperate, drowning in paperwork. So they'd quietly, on their own devices, use something like ChatGPT to help draft a letter or summarize notes.
But they were doing it in the shadows because they weren't supposed to be.
Precisely. The sources lay out 3 huge barriers that stopped any health system from actually scaling this up. The first one was just a legal firewall, the lack of a BAA.
A BAA, that's a business associate agreement.
Correct. And in the U.S. healthcare system, if you don't have a BAA, you just can't touch protected health information, PHI. It's the whole legal framework. The free version of ChatGPT you use to write a poem, it didn't have that. So a doctor putting patient info in there was, potentially violating federal law.
Okay, so barrier number 1 is legal jail. What was number 2?
Zero traceability, or what we all used to call the hallucination problem.
Ah, right, the creative writing problem.
Exactly. General LLMs are designed to predict the next plausible-sounding word. But in medicine, you don't want creativity. You want boring accuracy. These general models, they didn't provide citations. If the AI said this patient needs X, you had no idea if that was based on a real clinical guideline or if the model just made it up.
And I'm guessing the robot made it up is not a great defense in a malpractice suit.
Not at all. And then the third barrier was opaque data handling. The compliance officers at a hospital, their whole job is to keep the hospital out of trouble. They had no audit logs, they couldn't see who was asking what, where the data was going. It was a total black box.
So legal risks, accuracy risks, and compliance risks. The trifecta of no.
Exactly.
And that's what this 2026 pivot is built to solve. The source material says OpenAI is turning AI from a liability into a regulated operational accelerator.
I love that phrase. It just reframes the entire thing.
So let's get practical. What does that actually mean on the ground? The research points to 5 core workflows where this gets integrated.
Right. And these aren't just theories. These are the actual ways the tech shows up in the exam room.
Let's walk through them. Number 1, and I think this is the one patients will feel the most, is ambient clinical documentation.
This is the game changer. Just think about your last doctor's appointment. Where was the doctor looking?
At the computer screen. Clicking boxes, typing.
Always. Their attention is split. They call it backs of heads medicine. Ambient documentation changes that. It puts a secure listening device in the room that records the live conversation and converts it in real time into structured SOP notes.
Okay, hang on. SOAP notes. I see that acronym everywhere in this research. What is that exactly?
It stands for Subjective, Objective, Assessment, and Plan. It's the standard format doctors have to use. Subjective is what you say, my stomach hurts.
Right.
Objective is what the doctor observes. Abdomen is tender. Assessment is the diagnosis. Plan is what you're going to do. Doing this manually is so tedious, the AI just listens to the messy conversation and puts it all in the right buckets.
So the doctor can actually look at me.
Yes. It restores eye contact. It completely removes that manual data entry from the visit.
That's incredible. It's like using high-tech AI to go back to how medicine used to be. Okay, number 2. Longitudinal chart summarization. That's a mouthful.
It is, but the idea is simple. Imagine a patient with a complex 10-year history. Heart condition, diabetes, a past surgery. Their electronic health record, the EHR, is hundreds of pages long.
It's just a mess of PDFs and old notes.
A total mess. And a new doctor has maybe 5 minutes to prep before seeing them. They're just digging through it blindly. This workflow uses the new massive context windows of these models to synthesize all of that into a quick, concise clinical snapshot.
So it's like the Cliff's Notes for your entire medical history.
Basically, yes. So the doctor walks in already knowing the important context without having to spend an hour digging.
Huge time saver. Okay, number 3. Automated care coordination. This sounds like the stuff that always falls through the cracks.
It so often does. Healthcare is a leaky bucket. We tell a patient, go get this lab test or see this specialist, but we rarely close the loop. This workflow identifies those gaps. The AI scans the record and asks, did the patient get that cancer screening we talked about? If not, boom, it automatically drafts a follow-up for the team.
So it's catching the balls that humans drop just because they're overwhelmed.
Precisely. It turns the medical record from a passive file cabinet into an active monitoring system.
I love that. Okay, number 4. Discharge and transition planning. I have a personal grudge against this one. You get discharged, they hand you a stack of papers with tiny font, and you're too out of it to understand any of it.
You are not alone. Readmissions, patients coming right back to the hospital, are a huge, expensive problem. And it's often a language problem. Doctors speak medical, patients speak English. This workflow generates patient-friendly instructions. It translates the jargon.
So instead of ambulate twice daily, it says,
walk around your living room twice a day.
Exactly.
It improves understanding, which directly reduces risk.
Finally, number 5. The source calls this one the missing piece, interactive patient engagement.
This is all about the inbox explosion from patient portals like MyChart. Doctors are just flooded with messages. Does this look infected? Can I get a refill?
And that's more pajama time, right? Answering those at midnight.
It is the #1 contributor to pajama time today. So this workflow automates the triage. It reads the message, understands the urgency, and drafts a personalized, evidence-backed response for the clinician.
But the doctor still has to approve it.
Oh yes, that's crucial. The AI drafts, the human reviews, and sends. It turns a 5-minute typing job into a 10-second review job.
So, okay, we have the workflows. We know what it does, but how does this actually get into the hospital? The material says there are 2 distinct paths for this.
Right, this is the toolkit part of the deep dive.
Yeah.
OpenAI is basically offering 2 ways in, the interface and the API.
Let's start with path 1, the interface. This is ChatGPT for healthcare.
Think of this as the ready-to-use out-of-the-box version. It's a clinical interface.
Yeah.
But unlike the consumer ChatGPT, this version has been tested against something called HealthBench.
HealthBench.
Yeah, it's a physician-led testing framework. They basically throw complex medical cases at the AI to ensure it's safe. And this version comes with 3 key features the free one doesn't. First is evidence grounding.
This gets back to the hallucination problem.
Yes, the responses here act more like a librarian than a creative writer. They use a technique called RAG retrieval augmented generation. So they pull from peer-reviewed research, and this is key. They provide transparent citations.
So if it tells you to do something, it links you to the study that says why.
Exactly. Second, it has operational templates for things like prior authorizations. And third, enterprise governance.
The boring but necessary IT stuff.
Single sign-on, user management, audit logs, all the stuff that lets the hospital IT director sleep at night.
Got it. So that's path 1, the ready-made tool. What's path 2, the API?
The API is the builder's engine. This is for the founders, the tech companies. This is where OpenAI basically says, here's our brain, here's the intelligence, you go build a specific product on top of it.
So this is where other companies come in to build specialized tools.
That's it. OpenAI knows they can't build every single niche workflow, so they provide the intelligence layer. The source mentions a few leaders already building on this, like a bridge, who are just laser-focused on that ambient documentation piece.
They handle the messy audio part.
Right. Or a company like Ambience Healthcare doing scribing and automation. Or Elise AI, which is all about that patient communication piece.
And the big advantage for those founders is that they don't have to build the brain themselves.
That's the founder insight from the research. A few years ago, you'd have to hire 100 PhDs to build a medical LLM from scratch. It was insanely expensive. Now, with the API, teams can just focus on workflow design and clinical adoption. OpenAI manages the intelligence layer.
It frees them up to solve the actual user problem.
Precisely. It lowers the barrier to entry in a huge way.
So bringing this all together, we're looking at a huge strategic roadmap shift. The source has this great before and after table that I think really crystallizes it.
It's a total paradigm shift.
Okay, first, infrastructure. We're moving from building custom LLMs from scratch to now leveraging HIPAA-aligned platforms.
Which just means faster innovation. You're building the car, not inventing the engine every time.
Second, compliance. Moving from seeing AI as a risk to manage to seeing AI as an auditable, BAA-backed asset.
And that is huge for the hospital C-suite. It goes from being this scary thing they have to block to a valuable tool they want to deploy because they can track it.
And third, the value prop. This is key. Moving from just smarter answers to seamless EHR and workflow integration.
That's everything. It's not about just being smart. It's about fitting into the doctor's actual day, solving that last mile problem.
There's a quote in here that just jumped out at me. It says, "The move fast and break things era of AI is over in healthcare."
It really is. I mean, in Silicon Valley, that's the motto. But in healthcare, you can't break things. The things are people. You break something in a hospital, that's a patient safety event.
People do tend to get upset when you break them.
They do. So this new era is all about responsible scale. It's about slowing down just enough to ensure safety and accuracy so that you can actually scale up massively without hurting anyone.
So to wrap this up, the big picture here is a move from a world where our most highly trained doctors spend half their lives as data entry clerks,
Typing in their pajamas.
to a world of ambient intelligence, where the chart writes itself, the history summarizes itself, and the follow-ups happen automatically.
It's a transition from burden to genuine support.
And for you, the listener, whether you're a patient who just wants your doctor to look you in the eye for once, or a tech professional watching how a regulated industry finally adopts AI, this is the blueprint.
It is. This is the maturing of the technology.
Now, before we sign off, I want to leave you with one last thought. The expert always has something for us to chew on.
Well, as we look at this future, right, where all the robotic tasks, the documentation, the summaries, the coordination are handled by the machine, it raises a really profound question about what we do with that reclaimed time.
Right. Where does that freed up time actually go?
Ideally, we say it frees up the humans to focus on the one thing AI can't replace. Empathy, connection, actually holding a patient's hand.
Yeah.
But we live in a system that often prioritizes volume above all else. So will that happen? Or will the system just look at that save time and say, great, you're more efficient. Now you can see 40 patients a day instead of 20.
Oof. So do we use the time for deeper care or just for more volume?
That is the big economic and ethical question we have to keep asking as these incredible tools roll out.
That is a heavy but very necessary thought to end on. Thank you so much for guiding us through all this.
My pleasure.
And thank you all for listening to this deep dive. Don't forget to check out our sponsor, AI Opportune, for more incredible insights. We'll see you next time.